Hello, and welcome to today's UPMC video webcast event. As a reminder, during today's virtual event, you may submit questions at any time for our presenter by typing in the Ask a Question box below the video window of your webcast screen and clicking the Submit button. These questions will be answered after today's formal presentation. It is now my pleasure to introduce today's presenter, Dr. Robert Friedlander. You may proceed, sir.
Thank you very much. It's a pleasure to be here with all of you today, speaking from Pittsburgh, the University of Pittsburgh School of Medicine and UPMC, talking about a topic that's one of my favorite ones to discuss, Chiari malformation. So I will make a presentation. It's about a half an hour or so, and then we'll have plenty of time for our Q&A segment. I will tell you there's a few pictures from surgery. A lot of patients actually like seeing them in videos, but I'll try to warn you if anybody's a little squeamish with it. So I will share my screen right now, start the presentation. Okay, so we'll be talking today about Chiari malformation. It's a type 1 Chiari, which is one that is seen in adults. So my comments today, for the most part, will pertain for adult patients with this disease. Historically, Chiari malformation was first described by Hans Chiari from Vienna. He was born in 1851, and at that point, as you can imagine, there was no imaging, and the way to diagnose a Chiari and the way that he found the syndrome is by doing a large number of autopsy studies. So what I will cover today are, what is Chiari malformation? What are the symptoms? Should somebody be treated that has a Chiari malformation? Also, when they should be treated. I'll talk a little bit about different surgical approaches and strategies that I've used over the years, management after surgery, and outcomes. So again, a Chiari malformation is an animation looking at the side of the head. And what's key here, it's the foramen magnum, which is the opening at the base of the skull where the spinal cord exits. What happens in Chiari malformation is that part of the skull might be a little bit small, and the cerebellar tonsils may herniate down, putting some pressure on the spinal cord, as well as blocking the free flow of the cerebral spinal fluid from the brain. When there's that blockage, that's when people can get a headache because there's increased pressure in the brain. And that's essentially what anatomically what a Chiari malformation looks like. For people listening, there's a review article I recently wrote and was published a couple of months ago in the New England Journal, which is also appropriate for physicians and non-physicians as well. So in a normal patient without Chiari malformation, this is a side view of the skull. Foramen magnum is here in the bottom, and what you could see is that the cerebellum does not go below the foramen magnum. What happens in Chiari is that because this back part of the skull is a little bit small, is usually the reason, the cerebellar tonsil herniates down, and the CSF, the cerebral spinal fluid from the brain, is blocked off, so it cannot freely flow through there, as well as there's pressure on the spinal cord. And people get symptoms for a number of reasons. Pressure on the spinal cord, you can get some numbness or weakness, as well as when the CSF does not freely flow from the brain, that's when you can get the headaches, which are typical symptoms from Chiari. What are the reasons that this happens, and what are the points of a blockage? So there's 4 mechanical issues resulting in compression and impaired CSF flow. You have the bone in the back of the skull, as well as this was called a C1 arch that's there, that is pressing on that area. That is normal if there wasn't herniation. So you have pressure from the bone, you have pressure from the coverings of the brain called the dura, you have the cerebellar tonsil itself that it's compressing tends to flow, and there's some, and I will show you some pictures where there are different structures that block the flow of CSF at the foramen of Magendie. So the way that we fix it essentially is we remove some of the bone, what's here in red. The dura is open, and we expand the dura. The tonsils themselves what we need to do is release adhesion. Sometimes they're scarred down there, as well as what we are called coagulate them, so we can shrink them to create more room. And then we go deeply into the foramen magendae and open it up if there's some scarring there as well. And as I said, I will show some pictures to illustrate those findings. Now, I will give you, some examples here. So in the preoperative evaluation, what's key is the history. The history itself is incredibly important to be able to make a decision if the Chiari malformation is symptomatic or not. As a note, about 1% of people walking around have anatomically a Chiari, but not all of them are symptomatic. So the key is, one, does the patient have an anatomical Chiari? And that's determined by an MRI study, as well as if that Chiari that patient has is symptomatic or not. So those two are the key features in the evaluation of the patients. Now, when I see a patient that gets referred to me with a Chiari, I essentially put them in 2 or 3 different categories. The ones on the left, where there's very, very typical symptoms of Chiari, the imaging is pretty clear cut, and the decision to recommend surgery is very straightforward in that matter. There's patients that the symptoms may not correlate, or the imaging is just not really a Chiari, and those are the ones on the right that are just not Chiari, and that they would not obviously benefit from a Chiari surgery. And there's lots of shades of gray. Now, if you only operate on patients in the category on the left, the white, obviously those patients will do very well because those are symptomatic from Chiari. However, if you just limit yourself to that, then you're not helping a number of patients that really takes experience and knowledge to be able to determine if their symptoms are related to the Chiari malformation or not. Now, the headaches can be variable in location, but most often is in the occipital area, the back of the head, and they're what are called Valsalva associated. Valsalva is when you cough, sneeze, strain, laugh, cry. Can also happen when you're bending over or changing positions. That bottom part of the brain gets compressed a little bit into the foramen magnum, and that creates that pressure buildup, and the patient gets a sudden headache, or a headache, again, that's mostly in the occipital area, which it can resolve pretty quickly. Many patients come in and they say they have migraines. I always ask them, what do you mean by migraines? Because migraines mean different things to different patients. Some patients will come with very typical Chiari headaches, and they're calling them migraines. And what also happens is that sometimes other doctors will go and just not think that these are Chiari headaches because the patient calls them migraines. So again, it's very important to determine that as well. Numbness in the hands more commonly than in the feet. That's a very, very typical symptom of a Chiari, worse in the fingers. And usually, and it's different than from a herniated disc. From a herniated disc is what's called radicular complaints. It's usually one finger or another finger, and Chiari is usually the whole hand that gives you this. And then there's some other symptoms associated with this. Many patients with Chiari have tinnitus. They describe a tinnitus, which is, again, a noise in your ear. That's very typical. A lot of people have it, but people with Chiari have it. And the reason I know it's associated is because many of them, after surgery, will tell me, oh, my tinnitus is gone. And I think it's a result of the turbulent flow of the cerebrospinal fluid right at the level of the foramen magnum. Other symptoms that are typical is difficulty swallowing. They feel like there's food that gets caught up in the back of the throat. They can't really swallow it. Many patients have had a number of different swallowing studies, as well as dilation of the esophagus sometimes, and these tend to improve after surgery. Blurry vision, double vision, dizziness, and vertigo, those are other symptoms from Chiari. Now, one of the things that we've been doing a lot of research on is that many of my patients complained of brain fog. Their memory is just not the same. And most patients with Chiari, the adults, present between 20 and 40 years old, and a 20 to 40-year-old shouldn't be having memory problems. Again, this raises a flag that there's a problem there, and we've been doing a lot of research, as well as many patients with Chiari also have psychiatric manifestations, depressions, anxiety, OCD, hostility, and others. Imaging, you want to have the tonsils herniated between 5 millimeters or greater. Lesser herniations can also result in a symptomatic Chiari. I also look at the foramen magnum and seeing that it's crowded. Patients with Chiari sometimes have a syrinx, which is a cyst in the spinal cord, which presents a different set of issues, as well as signs of elevated intracranial pressure as well. One of the components that's very useful in the study when we obtain an MRI is what's called the CineFlow MRI, where we see the flow of the cerebrospinal fluid. If it's blocked off, it's very helpful, but it doesn't need to be blocked off to cause symptoms. But again, it's an important part of the information. I'm not going to go through details of the surgical strategies. Needless to say, I've been doing this surgery for about 25 years now, and the more that I do, the more that I refine the technique for patients to obviously do better, have less postoperative pain. I'll talk about that most of my patients go home one day after surgery, and again, is by doing a number of different things with the recovery of the patient. In terms of a surgical technique, again, not going to go over too many details other than, there's a standard amount of bone that I remove. I always open the dura. Different surgeons do this operation differently. Some people do a bony-only decompression. I don't like to do that, particularly in adults. Usually I open the bone, open the dura, go in with a microscope, and really evaluate. CSF supposed to be freely flowing to make sure that's completely open. I coagulate and shrink the tonsils for there to be more room, and then I put a patch over it to create more room there. I've done a lot of studies in looking at different materials as a graft, for example, bovine pericardium versus alloderm. And what I found is that the alloderm is a much better product for this. There's less CSF leaks. There's less what's called chemical meningitis, which is not an infectious form of meningitis, but patients are more likely to need a VP shunt after doing this. So I exclusively used into this. So the surgery itself, again, what we need to do is correct the problem, which is not enough room in the posterior fossa where the cerebellum is. So we do make an incision, usually about 5 to 7 centimeters, starts where you have a bump in the back of your head and ends about where the hairline ends. The occipital bone, that's what we drill down and resect. What's also very important is to extend the opening at the bottom where the foramen magnum is, to really provide more room there. What happens afterwards is I take off the top of C1. I don't take out all of C1 because I found that it's not necessary, and it creates more pain and potentially more stability issues. We open the dura. We go in with a microscope. We open the tonsils up. Often we find scarring in there or different kind of membranes that are important to resect. Otherwise, the CSF won't flow in an unobstructed manner. And then we coagulate the tonsils so they shrink up, and provides more room there for the free flow of the cerebrospinal fluid. And then we put the graft in, which we suture with very, very small sutures, just so that there's no leakage there. Now, so this is what I showed you on the left before surgery, where the bone and the dura and the tonsils, and on the right is what it looks like after surgery. What you see in purple there is the patch itself. So we've removed bone from there, so there's significantly more space there, so that the CSF can flow freely, and we've relieved the pressure on the spinal cord. So I'll show you one case here. For example, is a 20-year-old female who had a mild trauma, and that sometimes triggers the beginning of symptoms. It's a patient that already had herniation, and sometimes trauma or different issues can trigger the onset of the symptoms. Patient complained of a headache, which is worse when she coughs or sneezes, tingling in the hands. And again, this will be a surgical video, so if it's something you don't want to watch, here's the warning. So again, here's the MRI, and this is the foramen magnum, where that area is very, very tight. There should be some white, which is the CSF. And here you can see on the right, the cerebellar tonsils being herniated down pretty significantly. So this is the surgical aspect. That was the incision. That's the amount of bone that's removed. That's the occipital bone. This is the dura, the coverings of the brain that are being opened under the microscope. And you could see there's what we do is we tent the leaflets of the dura so we can go in and operate on the deep parts of the posterior fossa there. And what you can see here is the tonsils, which are herniated down quite a bit. This is a membrane that we open up. And what you could see is when we spread the tonsils, that you could see a little bit of CSF flowing there. We coagulate the tonsils so they get a little bit smaller. And you could see before surgery and after surgery, there's the room there. Afterwards, we put the patch in to provide more room. So again, this is the top of the head is up on the top, and the bottom is towards the bottom. Here, what I'm showing is that's the lamina of C1, which I just bite the top of it and remove it. Here are the two tonsils, and they're blocking the fourth ventricle. The fourth ventricle is deep to this, and that's the problem. Now, one of the things and one of the reasons I always want to open the dura and look down is some patients more and more have a blockage of the fourth ventricle by membranes, and I'll show you some pictures with it. So here's a patient that had arachnoid membranes blocking the fourth ventricle, and that's why on top of the Chiari, the CSF wasn't flowing. Here's another patient where the fourth ventricle itself was completely blocked by a membrane, which again, unless you go in and with a microscope in that area, then you're not fixing the problem. So here's that membrane, and this is after the membrane is resected. Deep in here, that's the fourth ventricle where the CSF can now freely flow. Again, another case with lots of membranes there that unless you open those membranes up, the cerebral spinal fluid is just not going to properly flow in that area. So it's important. And that's why I always go in and open all that areas. Fairly frequently, I do revision surgeries of patients that have had surgery elsewhere, either if they don't open the bone or they don't go deep into the foramen magnum and into the fourth ventricle, then the whole issue is not solved. Not every patient has this, but just that you're not able to see that beforehand. This is an example is a patient that I found a tumor that we could not see on the MRI. So here's the fourth ventricle here, and what you could see here is a small tumor that we were able to resect, and now you could see the fourth ventricle being completely open there. So in general, what we see is again, this is what the Chiari looks like before we do a lot of the manipulation. We've taken the bone off there, we've opened the dura, and what you could see is the tonsils themselves are pressing onto the fourth ventricle, which is here, as you can see on the right. So by being there, it blocks the flow of CSF. Every time you cough or sneeze, that gets impacted down a little bit, and it impairs the flow. So what we do is we open that, I free up all the little arachnoid adhesions which may be there. The tonsils, I coagulate them and shrink it so that then there's unobstructed flow of CSF. Some surgeons resect the tonsils themselves. I prefer not to do that because sometimes that can cause more scarring, but certainly a valid way of treating this issue. And afterwards, we put a patch over it. Now, this is, again, just to show you what a normal MRI looks like. Panel A, you could see the cerebellum that does not go below the foramen magnum where my arrow is. And you could see on this axial image that you could see the spinal cord surrounded by this white signal, which is the fluid of the brain. Here in Chiari, what you could see is that the tonsil itself is herniated down below the foramen magnum, and in that axial image, in contrast to in panel B, where you see the white for the cerebral spinal fluid there, this is all blocked off because here's the spinal cord, and in back are the tonsils, and this is what it looks like after surgery. We've created all this room here. That's the bone that's being resected. After surgery, as I said, there's a number of things that I do to try to optimize the rapid recovery. We remove the Foley immediately in the OR to try to prevent urinary tract infections. We've been given ketamine, a very low dose of ketamine, which really helps in the medication that'll reduce the need for other medicines. We use IV Tylenol. I use steroids while they're in the hospital, and when they're discharged, what's called a Medrol dose pack, which will give them a sliding scale of steroids for a number of days. Really important to have aggressive stool softeners during surgery and afterwards. Patients that use narcotics for managing the pain, they can get very constipated, and straining for a bowel movement is really bad for the repair. So we give them a lot of stool softeners. Patients stay in the recovery room for about 2 to 3 hours. They go to the regular floor. And as I said, most of my patients are going home post-operative day one. I do quite a bit of revision surgery from patients that have been operated elsewhere. And what I find in terms of the reasons is either there's not enough bony removed, or particular in the level of the foramen magnum, it's not opened widely enough. The tonsils are not shrunk or coagulated. The fourth ventricle is not opened up. Also, sometimes people have scarring that results after surgery. And what you see with these patients sometimes that they feel better for a number of 2 to 3 to 4 months, but then the symptoms recur. And again, it's because of scarring. And if a patient has that improvement and thereafter deteriorates, potentially is because of this. We do repeat imaging, do a cine flow. And what's interesting, sometimes patients will say that, patients that had ringing in their ears, tinnitus before surgery, that got better. When the scarring comes back, they get the tinnitus again. Again, it's a sign of turbulent CSF flow at the level of the foramen magnum. This is what it looks sometimes when we do revision surgery. There's lots of scarring. The tonsils themselves are scarred very, very significantly, which again, sometimes makes it very challenging to open up. And here is, after all that scarring's been opened up, and you could see directly into the fourth ventricle. Revision surgery is again just it's a little more difficult than the original surgery. And that's why it's important to try to get the first operation done as well as possible. Here is just showing some of my data of is the more that I do, the better that I get, but looking at length of stay. So this is from 2014 to 2024. You can see that, this line continues to go down. And as you see, in 2014, my average length of stay was 2.7 days, whereas now in 2024 the data for 2024 is 1.4 days. And here's the volume of cases that I've done. Chiari was part of my practice until maybe 2 or 3 years ago is a more significant part of my practice. Last year, I did 72 cases is an example. When we talk at symptoms before and after, and this is data from 314 operations, the most significant symptom is obviously the headache, which is improved or completely gone in most of the patients. Some patients still have headaches afterwards. When you paresthesias, so the blue is before surgery and the red is after surgery, difficulty breathing or difficulty swallowing, again, a significant improvement. My reoperation rate is about 1.2%. My patients that need VP shunts, when you look between 2011 and 2022, is about 5%. And if I look at the later half of this period of time, is 3%. So again, there's different things that I do to try to prevent the need for a VP shunt. But some patients will need a VP shunt because they have high pressure of the fluid of the brain on top of the Chiari, so that they'll need a shunt no matter what. Rates of CSF leaks, which is one of the complications when you do an intradural procedure. Again, for this period from 2011 to 22, 2.6%. But if I look at my latter half, is about 1.6%. So again, as a surgeon, we continue to improve and get better the more that we do the surgery. Now, one of the things that I found with many of my Chiari patients, as I mentioned at the beginning, is that patients complain of brain fog or memory problems. And as I said, patients in their 20s or 40s shouldn't be having this. And the more surgery that I did afterwards, patients would say, my memory is better. So what we did is we did very formal neuropsychological evaluations with a neuropsychologist that did a formal battery of tests. And then we would do one after surgery. And, what we found is that in the preoperative one, and these are, again, it's a selected group of patients that complained of cognitive issues. There's some very specific domains in the neuropsychological evaluation that definitely there was clear memory problems with them that the neuropsychologist detected. The other part, which again was not too surprising, but it was important to have it documented, is that there's a very high incidence in these patients of, as I said, depression, anxiety, somatization, obsessive compulsive disorder, hostility. And these are all very, very clearly abnormal there. And what we found is that when we did our evaluation 6 months after surgery, 89% of those patients had improvement in at least one of the domains, either on cognitive or psychiatric. 32% of the patients demonstrated improvement in both cognitive and psychiatric domains. 56% demonstrated improvements in at least one cognitive domain, and 65% demonstrated improvement in at least one psychiatric domain. And the psychiatric component was really more remarkable in terms of the level of improvements there. Here, what you can see is each vertical set of dots is one patient. So the blue is before surgery and the red is after surgery. The higher the number is, the better the memory, the lower, the worse the memory. And you could see many of the patients that had cognitive and memory difficulties were better after surgery. And the ones that had the worst memory are the ones that experienced the most improvement after surgery. So again, this is the first time that in the literature this was ever documented, that there's a memory improvement before and after surgery. Looking at the psychiatric symptoms, again, here the higher is having the disease. I mean, in blue, see a pretty significant number of patients that had depression and all these other symptoms, and after surgery, a lot of them improved. And again, the ones that had the worst depression are the ones that tended to improve the most. But again, each different. Not every patient is the same, but statistically, there was a difference in all of these kinds of symptoms. And again, this is the first time that anybody could show that this was an issue. One of the things that happens with a Chiari patients is they come in with these kind of symptoms, and some neurosurgeons will say, oh, this is not your problem, you're depressed or other things, but it's part of the disease. Here's the reference, which was published recently in the Journal of Neurosurgery, if anybody wants to take a closer look. So why do patients with a Chiari have cognitive and psychiatric complaints? Well, one thing that we're learning more and more, there's a lot of connections between the cerebellum and different parts of the brain. So obviously, if the cerebellum is not working properly, is under pressure, then there's symptoms in the brain that can be affected. Lesions in the cerebellum can also affect behavior in animals. There's a syndrome called cerebellar cognitive affective syndrome, CCAS, where patients that have focal cerebellar pathologies come in with, again, cognitive and psychiatric symptoms. So very, very similar to what we're seeing here. And again, I think that the role of transient elevation of the intracranial pressure also plays a role with this. Here is, for example, I'm showing you what we call here high definition fiber tractography. It's a way that at the University of Pittsburgh, we're able to see the connections within the brain, and here connections between the cerebellum and different parts of the brain. There's the frontal area, there's the posterior frontal area, this is the parietal area. Here, there's the temporal lobe, which controls a lot of memory and other kinds of personality components. And again, this is all going from the cerebellum. So if the cerebellum is affected, you can imagine there being other symptoms there. So I'd like to read this. The lack of broad recognition of psychiatric distress in Chiari patient often results in a misinterpretation of the presentation as psychosomatic, meaning some doctors will say, wow, this patient is depressed. I mean, the headaches really have nothing to do with it. And what's really important, and what we've demonstrated in our study, is that both the memory and the psychiatric symptoms are part of the symptoms. So as I conclude, what's key and what requires good imaging, but also is really important having a neurosurgeon that's experienced in evaluating Chiari patients. And one of the things that we do here at UPMC is that we're the largest department of academic neurosurgery in the country. We're very, very subspecialized. So I pretty much see all or most of the Chiari patients in our hospital, generating a lot of experience there. Patients can have variable imaging. In adults, I believe in opening the dura for a lot of the reasons that I described. We've demonstrated that the cognitive and deficit and psychologic abnormalities can be reversible and is part of the symptom, and something that we're calling Charcot's, which describe a Chiari-associated reversible cognitive and psychiatric syndrome. What I'd like to do is for you to hear from, there's a little video from one of our patients that I'll show in a second. As I mentioned, this is an article that I published recently in the New England Journal, and it's a review that provides a fairly detailed description of Chiari and treatments and options. So again, UPMC did a little piece on one of my patients. So I'd like for you to hear from her.
It's Indigo, baby. My name is Megan Barp, and I am the president and CEO of United Way in Greenville, South Carolina. I've had headaches my entire life. In 2021, my Chiari malformation was discovered.
It's a malformation of the back part of the skull. I've been doing Chiari surgery for about 25 years now. I've operated on hundreds and hundreds of patients, evaluated thousands of patients.
The surgery was very scary for me. Traveling to the doctor who's known for doing this work and the absolute best place in the world to have this done was not daunting to me.
We have a concierge service that really helps them from A through Z.
I have not had headaches since I had surgery. It is amazing. The thing that I'm able to do now, really truly whatever I want to do.
Look at that.
I don't have those limits anymore because of a headache. Dr. Friedlander and the team around him, that made it a very easy decision for me.
Okay. Well, we have a team that evaluates and takes care of our patients. I want to acknowledge our three physician assistants, Rachel, Lucy, and Jada, as well as Dorothy, our nurse, that helps with the management of the patient. So the same way that I need to become very good at evaluating patients, the whole team takes care of it. Luke Henry and Natalie Sherry are our neuropsychologists that do the neuropsychological evaluation. Peter Strick is the chair of the neuroscience department and has a tremendous amount of experience in the cerebellum, as well as some of our residents and our whole team, which helps us in managing patients. So again, thank you very much. Happy to take questions. So here's my email as well as our office phone numbers. So. This, and we'll stop sharing the screen. And we'll go to the questions. Well, I see a lot of questions here. So our first question is, prior to getting surgery for Chiari, do you check for other issues such as serings of the whole spine or of the cervical spine? The vast majority, the top part of the cervical cord, which is usually included in the brain MRI, unless patients have symptoms, which to me would raise a question of it. I don't usually image the whole spine. Let's see. Do you offer any other treatment if someone is not ready for surgery, such as pain management? I don't do that. It's the challenge with Chiari is that as I say, it's a mechanical problem, needs a mechanical solution. The medications don't really help if it's a Chiari, but could certainly decrease the pain, and it's something that usually a pain management doctor or a neurologist here at UPMC, for example, we have neurologists that specialize in headaches, and usually they're the ones that would manage that. Many patients come in actually with they've had the diagnosis or the question of a migraine, and they get migraine medicines. And one of the ways of figuring out that Chiari is the problem is that the migraine medicines don't help. Another question: what is a borderline Chiari? So borderline would refer a little bit more to the imaging. Some people define it as 5 millimeters of descent of the tonsils. Some people say it's less. There's something called Chiari 0, which you don't have to have any reduction at all, but a patient has a syrinx, and there's lots of nuances there. So really, what's important is not so much how many millimeters of descent the tonsils are, but really putting it all. How crowded is the foramen magnum? Are the symptoms very typical symptoms from this? Another question is, I have headaches and tingling hands. Sometimes should I be tested for Chiari? Good question. Be important for your doctor to see you. The headaches, it's when we look at the headaches that are the typical ones, which is we described the Valsalva associated headaches. Those are very typical of Chiari and tingling in the hands. So that could be similar, but there are many things that can cause headaches and tingling in the hands that the doctors should evaluate, and having a brain MRI under those circumstances certainly is very reasonable. I live out of state. Do you offer virtual appointments before I travel to Pittsburgh? Yes, we have many patients that travel from far areas to come here, and we're very used to dealing with patients that need to travel and they're not at home. We do certainly do telemedicine visits beforehand to get a sense of what's needed. Does Chiari run in families? Yes, but not. There's some diseases that are very, very genetic in nature, that they have a strong predilection of running in families, but the association of Chiari in families is not zero, but it's just low. Will I need to go to physical therapy after surgery, and if so, how often? Vast majority of my patients don't need physical therapy after surgery. The fact that many of the patients are young, between 20 and 40 years old, they're in good health and good shape. Otherwise, so usually we don't prescribe physical therapy afterwards. What I do after surgery is usually I see the patients 2 weeks after surgery, when we get the sutures out, evaluate him, and at that point, we clear him for driving, as long as they can turn their head pretty well and are not taking narcotics anymore. I ask them for a total of 6 weeks after surgery for no heavy lifting. Heavy lifting, I define that as 5 to 10 pounds, just to allow for the patch and the wound to heal properly. And that's that. So again, the vast majority of the patients don't need physical therapy. I had surgery in another hospital. I'm still having symptoms. How can I find out if I need revision surgery? So what's important is for the neurosurgeon that would evaluate is to get a very careful history, in particular, meaning what were the symptoms beforehand, what was the imaging. Convince yourself that the reason for the symptoms was the Chiari. Did the patient get better after surgery and then worsen? That suggests scarring in that area. Often you need an MRI with a cine flow to be able to demonstrate that there's some obstruction of the flow of the cerebrospinal fluid. After surgery, will I need to have multiple MRIs to confirm progress and healing? My standard protocol is the patients, they have the surgery. I usually don't get any imaging in the hospital or afterwards until 3 to 6 months. The patients that have a syrinx, I get imaging in 3 months because I want to obviously make sure that their symptoms are better. And the syrinx often becomes smaller with time. So I want to make sure the syrinx is going in the right direction. For the patients that don't have a syrinx, I see them at the 6-month point with an MRI. And if everything's fine, I don't get any more images in patients that don't have a syrinx. The patients that have had a syrinx, I may follow them every 6 months or a year. That would be tailored a little bit more. Is there a certain time unto patients which patients with Chiari has been chronic, to which prolonged stress on the brain tissue will not reverse the symptoms with surgery? I would not say that's the case. The issue is not so much the brain part, but if a patient has a syrinx, the more chronic the syrinx is and the larger the size, as well as for the symptoms to improve themselves. So from a brain point of view, if there's obstruction there, it's not so much is has it been too long with obstruction? Is more that opening can reverse that and can block from there being progressive symptoms and progressive deterioration. One of the things that we're studying is the relation between the chronicity and cognitive issues. I mean, do patients that have Chiari, if it's not fixed, do they have progressive Chiari cognitive deterioration? And at this point, we don't know. We're doing research on that. How long does the surgery take? So the surgery itself is about 2.5 hours. The whole time from getting into the OR and out of the OR is about 4 hours, roughly, because the anesthesiologist does their part. Then we have to very carefully, which is a critical part, position the patient so there's they're well. Move, but of surgery time itself is about 2 to 2.5 hours. Is surgery always the best option, or can symptoms be improved by exercise or diet changes? If the patient's symptoms are related because of the anatomical abnormality, there isn't enough room in that part of the skull and the brain. It needs a mechanical solution, so it needs surgery to be able to open it up. So exercise or diet changes would not improve this. There's some patients where part of the problem is the flow of the fluid of the brain. Weight can also affect that to some extent. So again, weight loss can sometimes help, but often it doesn't make a difference. If I've been told I don't need Chiari surgery, can you help manage my condition or even offer a second opinion? So yes, I see many patients that is a second opinion, both either that other doctors have offered surgery or not offered surgery. And to me, where experience is really important is that slide that I had in the beginning, the gray area. There's the ones that are clear-cut are easy, but the ones that are just not so clear-cut, from having a lot of experience, you can get a sense of who is going to improve. So again, not doing surgery on those patients, you're not offering the ability to have symptomatic improvement for many of these patients. I refer to bone-only decompression, which is something that's used a little bit more frequently in the pediatric population. In part is because I think their dura might be a little more malleable and can expand a little bit. But for the most part, patients with Chiari I they're very similar symptoms, or the headaches, or numbness and weakness, or other kinds of Chiari, which I didn't discuss. But for the Chiari type, it's similar kinds of symptoms, just surgical nuances might be a little bit differently. What is recovery like? When can I get back to normal activities, work, etc.? So as I said, patients go home usually one day after surgery. And for the first 6 weeks, I ask them, take it easy. Take it easy is not being in bed all the time. Just no heavy lifting, nothing heavier than 5 or 10 pounds. And then, but I want them to be up and walking to avoid blood clots in the legs, and nutrition is really important, so you get a good healing. Very important to do all that, and then gradually I tell them to go back into their usual state. At 6 weeks, what I tell my patients is listen to your body. If something hurts, if something is bothering you, then just slow down. Things like violent movement, like roller coasters or things like that, really not great for Chiari patients. For the most part, you can have a normal life afterwards. My sister-in-law has epilepsy and also Chiari. How do they intertwine with one another? I think she has two separate issues. The epilepsy and the Chiari really are not commingled in terms of causes or therapy. So I think it's a good question. I think they're not related at all. Can surgery be done on over 55-year-old individuals, and what might be additional side effects because of age? So I hope 55 is not older, but we do the surgery on whoever needs the surgery, which is the vast majority of adult patients present between, as I said, between 20 and 40 and 50. I've done surgery a few times on patients as old as in their 70s, just because they became symptomatic at that point. But for the most part, patients that present between 20 and 40. For patients that may have health issues, we have our patients being evaluated by our specialized preoperative clinic with anesthesiologists, just to make sure that they can get through the anesthesia well. Do I operate on pediatric patients for Chiari? I don't. We have a phenomenal department of pediatric neurosurgery with subspecialists there, and in our hospital, at Presbyterian Hospital where I operate, we go down as low as about 14 years old. But for younger patients, those are best done by a pediatric neurosurgeon that's their specialty. And I think that is the end of the Q&A. So really been a pleasure to be with you here today. Happy to answer any other questions if they come up, and have a great day. Take care.